Surprise, surprise, the U.S. healthcare system is still the most expensive and lowest performing. That's the message from the latest Commonwealth Fund report called Mirror, Mirror 2024, a portrait of the failing U.S. health system. Why do we continue to be so terrible, and what, if anything, can be done about it? Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the senior advisor at Walgreens.
October is the season for masks and costumes, but some of us feel like we're wearing a mask all the time, whether at work, in social settings, or with family. Therapy can help you embrace all parts of yourself so you can take off that mask. After all, masks should be for Halloween fun, not for hiding our emotions. That's where BetterHelp comes in. BetterHelp offers entirely online therapy that's designed to be convenient, flexible, and tailored to fit your schedule. You fill out a brief questionnaire to get matched with a licensed therapist. Need to switch therapists? No problem. Make a change at any time with no additional charge. So whether you're dealing with stress, anxiety, or seeking personal growth, BetterHelp connects you with licensed therapists who can support you on your journey to rediscovering your curiosity and becoming your best self. Take off the mask with BetterHelp. Visit betterhelp.com/caretalk to get 10% off your first month. That's BetterHelp, HELP.com/caretalk.
So David, this Commonwealth report, we've talked a lot about how the U.S. has worse outcomes and more costs, sort of ad nauseum. What did we learn anew with the well, first of all, who is the Commonwealth Fund, and what are they telling us?
Well, you're going to have to tell me who the Commonwealth Fund is, John. I just know of them as a group that does good public health reporting. They've put this report out now for about 20 years. They started it. I think they do it every other year. And they try to measure things in an accurate way. So you've got 10 different countries, used to be 11, but Norway dropped out. They measure 70 different performance measures across 5 different domains in healthcare. The 5 are access to care, care process, administrative efficiency, and health outcomes. And they say, where does everybody rank on everything? And pretty much we're the worst on all those different elements. And then cost, they measure as a percent of gross domestic product. And we're not just the worst, we're actually a big outlier. You look at the charts and they're all bunched together, and then the U.S. is just off in the wrong corner in each one.
Yeah, just to be clear, the Commonwealth Fund is around, I think they're around almost 100 years. It's some great industrialist funded, it's a foundation. It's an independent foundation that does academic research that racks and stacks a number of healthcare issues. And the one that we keep coming back to is this evaluation of how well does the United States healthcare system perform relative to how much it costs, and then it breaks down that performance in the categories that you talked about. And we continue to do poorly. I frankly miss Norway because Norway was the second most expensive system in the industrialized West, and they left because of privacy reasons, but it's made us look even more extreme. Just to give people a sense of how expensive our healthcare system is, we spend about 16% of GDP or gross domestic product on healthcare. And, the countries, the industrialized countries that kind of look like us, Germany, Switzerland, New Zealand, Australia, the better performing ones in this survey are spending 4 to 8% of their GDP on healthcare. And they're getting, in general, better outcomes. So spending less, getting more in terms of measuring morbidity, mortality. What's going on here, David?
It's a little hard to understand because, sometimes you could say, well, you get what you pay for it. Well, we pay more, but we get more for it, or we pay more, but we get, maybe we should pay less, but at least we're getting the top. And it's really kind of the opposite. Australia and the Netherlands are the 2 highest performing countries in this comparison. And they're also the 2 lowest cost. And that does make it perplexing, John, to try to understand. And you have to start, I guess, searching for things that aren't specifically in the report to understand that one. I mean, I guess you could make like a car comparison. Like, so John, like I think you drive a Lotus or a Lamborghini, as I may recall. They're very
It's
nice.
a Lexus with 200,000 miles on it, but thank you very much.
All right. So anyway, so the Lexus is like you get what you pay for, right? It's strong performance. It's good. I think probably the equivalent of the U.S. in healthcare would be the Land Rover. You know, it's the most expensive, but it's always breaking down. I guess it looks good, and people like to brag about it.
Well, we're not going to get Land Rover or Range Rover to advertise on the pod, I guess.
I guess not, John. It is actually hard.
High budget, high breakdown.
It is hard to understand. So, I mean, the way to probe it, I guess, is to look. Is there anywhere where we're not, the worst? And the answer is yes. The answer to the question, is there anywhere where the best is no, but you do come in second in care process and last in everything else. So care process, we seem to be making progress on.
What? I mean, now that you've struggled to find a category that the United States is okay in, what the heck is care process, David?
Well, it's things like prevention, patient safety, care coordination, patient engagement.
That sounds good. What if we're number two there? Number two, that's a silver. Why aren't we doing well across the other categories of outcomes?
Let's say about why we are doing well here in this area, which is that, would you say you get what you should pay for sometimes, right? And we have actually been paying for care process. A lot of pay for performance measures are about care process, things like this patient engagement. When you get these surveys and they ask you how well engaged you are, there are actually incentives to do these things right. So maybe the positive thing is that if we do put money behind something specific, we can get there. But maybe we need to put the emphasis in somewhere other places, or these aren't as correlated with outcomes as we might want. Or maybe we just need to put the incentives into to the other categories, and we can move up there too.
Well, I think you should also look at where is the United States an outlier in a number of things that aren't going well. One is gun violence. We are a wild outlier in terms of gun violence. The most likely risk of death for kids is increasingly gun violence. We are an outlier in terms of care consistency of care coverage. 1 out of 4. I think there's still 36 million people who are uninsured, and they may go on and off the rolls. But when you don't have insurance, you're less likely to go to the doctor and get those preventive care stuff done. And even for those who are covered, obviously Medicaid expansion and Obamacare have extended coverage for many Americans who didn't have them. About 1 in 4 covered Americans is underinsured, which is to say that the cost of actually going to get the care you may or may not need is high enough because of copays and deductibles that people typically or consistently thinking twice and sometimes avoiding the care that they need. So we're paying for it, but not necessarily getting the care access. If you compare our system to others, there is much more of in the developed world. These are all developed world comparisons. Every other system has more consistency of care. Most other systems, all other systems have significantly lower costs, although some of them, do have slightly higher costs. Germany caps its cost share at a percentage of income. Most others do as well. We are definitely an outlier also in opioid addiction and deaths of despair. Increasingly, that is a significant category problem, not just for older adults, but younger folks. And I think if you think about drugs and violence and inconsistency of coverage, those have got to be feeding into, David, these statistics.
For sure, John. And I think that we need to remember that the goal is health, not healthcare per se. To be fair, one of the domains that they do cover is health outcomes. So it's not as though it's completely forgotten about. Maybe we can look to what does the U.S. do differently, so we might turn it into a positive force or reinforce it if it is. One area is just the amount of private investment that goes into healthcare. The report actually does a little bit of a tisk-tisk about private equity ownership.
It's worse than that. I think they're kind of insulting private equity ownership, but particularly of primary care primary care docs, and I mean, they refer to them as trading them like commodities, which I don't think is quite fair. In fact, I think private equity has actually been a significant source of capital in the primary care area, and if anything, I think that's at least from my perspective, a good thing. Certainly, where primary care, risk-taking primary care has failed, it's more about the management of those units than actually the capital providers who are helping them or trying to help them grow. And if anything, David, I think we need to spend and invest more in primary care because in our private system, the vast majority and the incentives within the institutions are to put more money into tertiary and quaternary care, the things that happen to you when you're getting a complex surgery or spending time in the hospital. And those incentives are backwards. I mean, I think that's probably an incentive system that's a problem for the U.S. system.
So let's dig into that primary care question a little bit. So primary care has been in crisis or in decline here in the U.S. for some time. And let's say if you take private equity aside, what was happening was people either just exiting primary care or selling their practices to hospitals that were using them as feeder systems into this more expensive care that you're talking about. So, absent policymakers actually making investments from the public standpoint, it's up to private industry to do something. And in this case, it's done it. Now, there's been pushback. First of all, there's been challenges in doing it because you can't fight the overall system. And maybe some of them haven't been managed as well as possible. But you also get then pushback maybe from the government saying they don't want private ownership here. And I think it's partly favoring the hospital systems. So if we look ahead and say primary care is still an issue, what's the role for private investment going forward, would you say?
Well, I think it really depends on where the incentives are. Currently, the reason why people are exiting primary care and hospital systems are still building bigger buildings is not just because of the aging of the population, because older people, as the baby boomers, 10,000 people turning 65 every day hit the system, we're going to need more primary care, more continuity of care with nurse practitioners, internists, general practitioners, and geriatricians. But we don't pay them enough. In fact, the number of geriatric residences is going down. That's those specialty that cares for the elderly, while the number of elderly is skyrocketing. And so I think we really have to look, given the fact that 52 cents out of every healthcare dollar is supported by taxpayers through Medicare and Medicaid and the federal government, as to where we put those incentives. We need, I think, fundamentally to set up and since the government's the biggest payer, it needs to actually think about reinvesting and expanding and increasing how it compensates primary care providers. That's the way I think you'd start to rejigger the system, because if the incentives in the U.S., which they kind of are today, are that you only get paid well if you're really sick, well, guess what? The system is very good at solving very complex illness, but other systems, it would appear, are much better at preventing that by providing much more expansive access to primary care because they pay better on a relative basis.
So as you say, the government is actually the main payer, over 50% or so overall. And so if there are going to be changes, they actually do have to be related to government policy. So even though there are a lot of private actors in the U.S., it's still, government is a major force. Government's been pretty dysfunctional too, so I don't know that we can count on that to bail us out. And one of the things that the report does is to provide that kind of roadmap for policymakers. So I think that's useful. So if we can just not just despair of whatever the government's going to do, what else can help us? So we've talked a lot about.
I mean, David, to be fair, your point about care access is a really interesting one.
Yeah.
Almost 20 years ago, a little bit more than that, the Institute of Medicine put out a report called To Err is Human, regarding it was a very methodical study of all the preventable medical errors. I think the estimate was that there are, whether it's adverse drug events or poor processes around surgeries, that we had the equivalent of 2 747s a week crashing and killing everyone aboard if you added up all of the preventable deaths in the healthcare system. That report had a really big impact. It was methodically done by doctors. It was pushed out and changed the way people hat tip to Togawandi on his checklist manifesto, the way people prepared and managed surgeries. It opened the door to people questioning whether teams of medicine, of doctors and nurses could actually have an open conversation about what was going right and wrong. It opened the door to the standardization of drug information so we could prevent drug-drug interactions. And I think if you look at where we are performing so well in care process, I think you could tie it pretty closely back to those early studies of what we can do. And that was really a information and cultural change, because the incentives really didn't, there were slight changes of incentives at the federal government. The federal government no longer pay for an avoidable hospital readmission, which is to say if they were supposed to fix something the first time and the hospital screwed up and you had to go back and fix it, they wouldn't pay for it twice. They wouldn't pay for a botched surgery. The incentives were on the margin. But I do think that, David, that was a remarkable example of where the culture changed based on data. And I think if we can find similar things, most people go into medicine and healthcare wanting to do the right thing. And that strikes me as an example over the last 20 years of a pretty material improvement in the way our healthcare system performs. And maybe there's something else that can be done there from the August ivory tower of a place like the Commonwealth Fund.
Good. Well, John, maybe if we combine that, so to end on a happy note or an optimistic note, maybe that same sort of call to action combined with some new tools, and think about AI, which is just starting to show its potential.
Always look for AI.
I look for AI, John. Yeah, you don't?
Well, no, I think maybe, but like, why should the computer, you really think the computer's going to help us here, David?
A lot of the issues here having to do with cost and with consistency are things that you might want to address with what you do with people. Now, the population is aging, birth rate is declining, immigration is declining. And so how are we going to address these things and not make them worse, which is probably the track that they're on. And I think AI has that potential. So, for example, if you want to be diagnosed correctly the first time without going to a lot of specialists and costing a lot of money, proper use of AI, including by primary care, can have that impact. And so I do see the option to, sort of to change the trajectory of that technology, in particular, if applied in the right way, if we're aiming it at the right things, instead of aiming at it, how can we, drive up cost or some other objective that's less.
Well, I'll give you one more positive there, David. Right. I'll give you a slight one, which is I think that the other place where we massively underperform, the United States system, is in administrative efficiency. We're massively inefficient because of all of the different parties in our semi-public, semi-private system. And, one of the things the Commonwealth report complains about is the complexity of all the different insurance products. Well, that's not going to change. But I could see a path where artificial intelligence, big compute, and just more technology applied to the administrative back end could significantly reduce cost and complexity in the supply chain, because it'll massively move through the complexity and simplify things so that we can actually get the care we need and get the bills paid the right way the first time. There's some basic things that I think AI and big compute could really contribute to. So there's a positive.
There we go, John. All right. Well, that's it for yet another episode of CareTalk. We've been talking today about the latest Commonwealth Fund report called Mirror, Mirror 2024. So take a good look in that mirror, John, and I hope you like what you see. And I'm sure as you get a little bit older, you'll like it even more. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, senior advisor at Walgreens. If you like what you heard or you didn't, we'd like you to subscribe on your favorite service.